Dear colleagues and friends, it is now our great honor to introduce Professor Haruhiro Inoue. Professor Inoue is a professor at Showa University and chairman of the Digestive Disease Center at Koto Toyoso Hospital in Tokyo. And Professor Inoue made brilliant achievements in endoscopy, not only in therapeutic, also in diagnostic endoscopy. I would like to remember on the classification of early esophageal squamous cell cancer. He introduced the first set to perform an endoscopic mucosectomy, the CAP EMR, and then he developed the submucosal tunneling technique. And I think, Haru, 14 years ago, you performed the first endoscopic myotomy in a human. And you got great achievements, and so you got outstanding awards. In 2022, you got the SAGES Award and also the George Bursey Lifetime Achievement Award, and I think this shows about your great achievements. And we are very honored to have you today here, and there's also another premiere, because today Professor Inoue will talk the first time outside of Japan about a new field of endoscopy, about functional endoscopy. And a new invention always starts when somebody genius questions things we are experiencing every day, but we never try to get to the bottom of. And I would like to ask you now, you are performing endoscopy every day, so have you ever observed or noticed or tried to describe how your patient is burping during your endoscopy? And Stefan and we would like to now show you two videos of patients with reflux symptoms. And please look at the videos, focus on the G junction and what you hear. Please start the video.
By the way, the sounds came from the patient and not someone else. So there's another video coming up. And also use your eyes and your ears. And maybe you might say, that's absolutely the same, but maybe there are some differences. Okay, everybody made up his mind, and you might say, okay, what do these guys tell us? That's endoscopy every day. We inflate air, patient can't keep the air, that's annoying. Really, what do you want to tell us? And that's our big question to Haro. What can we learn from a standard endoscopy? Was that already a diagnostic procedure? Please, Haro.
Thank you very much. It's a great introduction. So, first of all, I would like to say congratulations all the gastro members of the Hirschranden Clinic 30th anniversary. Congratulations. So I first maybe invited to this hospital, great hospital, maybe 10 years ago. So at the time, I'm coming to install the endoscopic submucosal dissection. Now the both Stefan performs a really great ESD. Maybe two of them are now the leader of the ESD, endoscopic submucosal dissection in the Europe. So, okay. So, it's a great audience, so it's a very difficult to talk this topic, not a poem. Topic of GERD. So it's it's a morphological part and of course a functional part. So I would like to talk a little bit about the morphological classification. This is a surgical textbook. So everybody knows type and type. So surgical textbook is very simple. And this is a famous endoscopic classification of a mucosal flap valve in a gastric caldera. So this is the Hill and the Kozalek, so they reported. So well accepted worldwide. So I would like also mention a little bit about the collar swing muscle later. So this is a sliding hernia patient. So at the top of the stomach is slipping to the mediastinum. So this is ours. So this is ours. So this is not a classification. This is a description method. So we simply classify the findings, endoscopic findings in a lateral flex view in the stomach, and the caldera opening, that is a horizontal opening, and also sliding hernia, that is a vertical component. So like this. So we can describe the condition level of our hiatal hernia, just the horizontal and the vertical deviation. So this is a horizontal part. So cardiac opening 2, 3, 4, 5, 6. This is a outer diameter of the endoscope is roughly 1 centimeter. So we can calculate. So using this. So 2 centimeters, 3 centimeters, 4 centimeters, 5 centimeters. Okay, like this. So another important factor, most important factor is a sliding hernia. That is a vertical deviation. The stomach deviates to the mediastinum. That is the most important. So like this way, so endoscopy is 1 centimeter. So we can evaluate, describe the condition of a hiatal hernia 0 to 3 centimeter. Okay, so some statistical evaluation, we can say that the horizontal opening more than 4 centimeter is well related, strongly related to reflux disease. And also this is the evaluation of the vertical deviation. Then, so we analyzed comparing the acid exposure time and the composite score. Then, so more than 3 centimeter deviation of the esophagogastric junction toward the mediastinum cause the significant reflux. So we can say that at this moment, so this may be the consensus. If the patient has more than 3 centimeter sliding hernia to mediastinum side, so we recommend the patient to receive the surgical repair of the hiatal hernia. So because we need to pull back the esophagogastric junction toward the abdominal part. So otherwise, so of course, you know the tracheal cavity is a negative pressure, so cause more and more reflux. So I would like to talk about the less than 3 centimeter, 1 or 2 centimeter sliding hernia with some opening of the gastric caldera can be treated by endoscopy. So next, I'd like to talk about the functional part of the GERD. So everybody knows. So lower esophageal sphincter. So lower esophageal sphincter is a one-way valve. one-way valve. That's the point. Okay, so this is some anatomical, endoscopic anatomical landmarks. So palisade vessel at the distal end of the esophagus, and also proximal end of the gastric fold is a good landmark to identify esophagogastric junction. So of course, a scrum-columnar junction is very easy to identify. So, as a previous demonstrated a very nice video, so when we perform the endoscopy on regular basis, so in the insufflation in the esophagus causes the relaxation of the lower esophageal sphincter. So we cannot observe the LES endoscopically. So this is a lateral flex view. So like a previous video, so this patient is not a GERD. We can recognize the scope holding by the contraction of the lower esophageal sphincter muscle. So we are insufflating in the stomach. Then, so LES try to avoid burping. Okay, so over-insufflation in the stomach, distension of the stomach induce the LES activation, and then avoid reflux disease, I think. So it's simply, I think, so when we drink a beer, and then so full stomach and the bump. So that is a normal situation. But in the case of a GERD patient, so quite often slow belching. Okay, so this is the same case. So left side and right side, the endoscopy image is in the same patient. In a forward view in the esophagus, we cannot observe the LES. But in a lateral flex view, right-hand side, you can see a strong contraction that catch the endoscopy shaft, and they avoid the leakage of the gastric gas. So this is activation of the lower esophageal sphincter. So as the previous two cases lose the function of the LES, then the patient have the slow belching. So we call this scope holding sign. So this is a asymptomatic patient. So sometimes in the case of a severe GERD, this patient has the very strong reflux symptoms. So we insufflate in the stomach, but no contraction, no activation of the lower esophageal sphincter. So patient keep burping. So no sound, I'm sorry, but the patient keep burping. So the question is, a contraction is really a lower esophageal sphincter or not? So we insert a high resolution manometry together with the pediatric scope. And the pediatric scope keep in a lateral flex view in the stomach. And you can see a catheter of high manometry. Then, so first the patient, this patient had the scope holding sign positive, and then so white arrow demonstrate the patient started to burp. Then so LES relax, and then we can also observe the pump pressurization of the distal esophagus. So in a single patient, so we can observe the scope holding time and also relaxation. So we can evaluate the scope holding time %. And so in a normal patient, it's impossible to observe the LES in a straight view, but in the case of achalasia, we can observe the contraction of the lower esophageal sphincter in a pathological situation. So, patient in a achalasia, of course, you know there's no relaxation of a sphincter. So this is a report of the esophageal offset sign in the esophagus. And also in a retroflex view, we can say, so last night we enjoyed the champagne, nice champagne. The champagne glass sign looks similar to champagne glass. Okay. So we are thinking the using regular endoscope, we can identify the contraction of the lower esophageal sphincter in a retroflex view. But in order to evaluate objectively, we thought that we have to calculate the intragastric pressure. So method is very simple. So just connect the tube to the part of the endoscope. That's all, and we can evaluate the pressure. So this machine is from the Kians. So anyway, so in a normal patient, not a patient, a normal population, so intragastric pressure increases. So we keep insufflation, and then so as the stomach is full, then the patient, the burping, rapid belching, then intragastric pressure is promptly down. So in the case of a GERD patient, so most of them demonstrate a flat pattern of the IGP. So this patient also has some opening of the gastric caldera, not much the sliding component. So we call this endoscopy pressure study integrated system. So IPSIS we call. We can evaluate the waveform pattern in two groups. So uphill, it's a normal pattern, and the flat pattern is for GERD. Okay, like this, this is a non-GERD patient. So in a lateral flex view, that we keep insufflating. Then intragastric pressure increases, and then finally it's a breakdown. So it's a very simple relation during endoscopic procedure. So a patient come to our clinic with a symptom of GERD, and most of them, we perform the endoscopy checkup and keeps a retroflex and insufflates the stomach. The patient has the slow belching. And it's well corresponding to the waveform flat pattern. That means low LES function. And in normal population, the patient has the rapid belching. It's a breakdown over scope holding sign by over insufflation. Okay. So, okay. So this is again this slow belching. Yellow line demonstrates, yellow bar demonstrate the sound. We can get it in the patient's neck, and the green line demonstrates the intragastric pressure flat, simply flat. And also endoscopic view, we can identify the open hiatus a little bit, but no sliding hernia. So this kind of the patient series is mostly a NERD patient. Non-erosive reflux disease patient can be treated by endoscopic treatment. Okay, so This is not just so rapid, but like this. So once again, this is a rapid belching. Okay, so next step, we understand that the slow belching is lower LES competency, and so we have to evaluate the relationship in between already established procedures. So 24 pH impedance and also endoscopic findings of GERD and high resolution manometry, we have to compare it. So first, I would like to demonstrate the data IPSIS versus 24 pH monitoring. So this is statistically analyzed, and then so the IPSIS GERD positive, the criteria is a flat pattern, and intragastric pressure maximum is lower than 18 millimercury. So this can be applied to our all GERD patient, and the most important is the NERD patient, the patient who has a symptom of GERD and the no hiatal hernia, sliding hernia. That is most important, and the IPSIS GERD positive, so well evaluate the NERD patient. So I think IPSIS is a kind of a tolerance test. So over-insufflation in the stomach and then try to activate the lower esophageal sphincter. I think it's similar to some stimulation test in endocrinology. Okay, so next I like compare the IPSIS and the erosive esophagitis and the Barrett esophagus. So, okay, so we evaluate the erosive esophagitis patients, the left side and the right side are negative, and then so IPSIS positivity. So it's a well-related red line demonstrate. So Barrett as well. So well-related. So in the case of erosive esophagitis, that's a typical GERD and the Barrett esophagus patient, so they have the IPSIS lower, intragastric gastric pressure is low, and the waveform pattern is flat. So next, we would like to evaluate the relation of the IPSIS versus high-resolution manometry. So, so first we independently compare the both. And the IPSIS definition is like this. So pressure difference in the starting the before insufflation, and the we can identify the peak intragastric pressure also before belching, and the it's more than the 4.7 millimercury, and the pressure gradient is a simple indicator. So in the case of normal LES function, the waveform of the gradient is getting sharp. So this is analysis. Then we have a good relation. Then so we can simply say that the if we can calculate the intragastric pressure, if it's when we insufflate, if it's rising up, so that means LES function is normal. And also If no contractions, the patient has the slow belching, that means the LES function is very low. So all these conventional well-established study demonstrate the significant, the well associated with other standard tests. So what I want to say is that the story behind is like this. So in our hospital, we talk to the patients, so please receive the esophageal motility test. So all the tests should be done before and after procedure. So particularly 24-hour pH impedance. So patient accept the before procedure. So because patient never experienced the 24-hour pH impedance, but after treatment, so it's we need the data. So we ask the patients to please receive their 24-hour pH impedance, but patients say, "Oh no, thank you." So maybe everybody has the experience like that. So I want to evaluate just during the endoscopy checkup. So even without actual data of the pressure, just concern the patient burping, we can imagine what happened. So of course, in a lateral flex view, and we can see a movement of the lower esophageal sphincter. So burping and endoscopy image and the burping, we can imagine what happened. So this is a normal situation. So once again, so NVI is very nice to demonstrate the squamous epithelium, well contrasted to the gastric mucosa. And then you can see contraction of the lower esophageal sphincter. That is located a little bit 1 or 2 centimeters higher than the scrum communar junction. Okay. So, yes, so waveform the increasing. Yes, again, this is the combination. And now this is a study basis. So using this technique, so pediatric scope mounting the high resolution manometry, and the inserted that keeps the retroflex, the pediatric scope. Then we can evaluate the at the same time, simultaneously, the image of the high resolution manometry, and also pressure study, and most important is the endoscopy image. So this is a case of the peristalsis of the esophagus, quite typical. So saliva is coming down to the stomach with the contraction. You can see peristalsis coming down, and then high resolution manometry demonstrate a good peristalsis. So during procedure, we can directly observe the what's happened. So of course, you are the specialist of the manometry, so without endoscopy image, you can understand well, but so we can really recognize well what's happened in the esophagus. Okay, so I would like to demonstrate 2 cases. So the Groth patient. So mostly I think the hypersensitive esophagus. Okay. So burping is flat, slow burping, And the yellow line demonstrates the sounds of burping, and the green line demonstrates the pressure, no increasing. So hiatus is open, and the scope holding is not enough. And in this case, we can identify no peristalsis. So esophageal clearance must be low. Okay. So this is another case. Okay. So in a straight view, straight endoscopic view, we can say almost normal junction. And then in a lateral flex view, we can identify endoscopically, morphologically, hiatus is open. And it's a 5 centimeter open, and the sliding hernia component is a 2 centimeter. And then, so we do like this. So this patient as well, just slow belching, and no increase of intragastric pressure. So, and also no peristalsis. So esophageal clearance must be lower. Okay. This is the same patient. So most of the narrowed patient is a hiatus is open. So if we insufflate the stomach well, we can identify open hiatus. So I think so. This is a short summary of the IPSIS. So dynamic and simultaneous visual evaluation of the esophageal motility of the lower esophageal sphincter and the esophageal body during a single examination of endoscopy. So first time the patient come to us, and we perform the endoscopy. So so far we just check the patient has the Rosengel's A, B, C, D, the erosion or not, and insert it in the stomach and keep lateral flex the sliding hernia or not. But now we can simply evaluate just insufflating the gas in the stomach. Then we can assess or imagine the fats happen in the patient. So of course, IPSIS has a limitation. This study should be done in a deep sedation. Otherwise, so a patient complained that today's endoscopic examination was a disaster. So it's a little bit some effect of the sedation. And also sometimes difficult to determine the waveform pattern. So I said that it's uphill and the flat pattern, but some patient is a moderate. So that is a limitation of this study. Okay. So next, so for the reason why we perform like this, so we want to pick up the patient who receives the endoscopic anti-reflux procedure. So our procedure is like this. So far, last the 20, 30 decades, 3 decades, we have lots of endoscopic anti-reflux procedures. So it's very difficult. So this is my experience in one patient. So we reported 2003, so now 2022, so 20 years ago. So 20 years ago, we experienced this patient. It's a patient with a severe GERD, and like this, a Barrett short segment, and the patient had the high-grade dysplasia. So we dissected, we decided, so this patient, all 7 biopsies and demonstrate the adenocarcinoma. So we decided to resect all this distal esophageal mucosa. So because we thought that this is an intramucosal cancer, not a submucosal cancer. Anyway, so this patient has a relatively large opening of the gastric cavity. Anyway, so we dissect all the distal esophageal mucosa, and then also we place some mucosal incision in the gastric side as well, circumferentially. So after treatment, patient satisfied very much. So reflux disease is actually well controlled. So patient, yes, satisfaction is very high. So this is the symptom score improvement, and also some pH and Biotech study at the moment. So, so surprisingly, this patient, so we follow this patient 12 years. So 12 years later, after mucosal resection, circumferential, that this patient esophagus is covered with the squamous epithelium. This light bottom image demonstrates the Lugo staining, so covered with the squamous, even after 12 years from the procedure. So then we think, even when the patient has no dysplasia, we can resect the mucosa to make the junction tight. So that is we call anti-reflux mucosectomy. So actually we did it in a gastric cavity. So if we do it in a esophagus, distal esophagus, patient has a dysphagia. So we have to do it in a gastric cavity. Nearly circumferential resection. So this is a case. So NERD patient, open hiatus, like this. So we place the mucosal resection semicircumferentially. And the point is to preserve the greater curve side. This is a mucosal flap valve, so we have to preserve it. So purpose of this method is to make the mucosal flap valve robust. That is a purpose of this method. Then, like this, 2 months after anti-reflux mucosectomy, the patient junction becomes tight. So this is a pH impedance study that 1 year after procedure, it's going well. And this is data of more than 100 patient series. So acid exposure time and also yes, a composite score also, these are well controlled. And this is a follow-up data, 3 years after procedure. So everybody knows, so after mucosal resection, after ESD, so stricture is very tight. So sometimes we repeat the bottom dilation, particularly in the esophageal mucosal resection. So once the patient had the scar formation, it stay longer. So 3 years, the patient keeps a good condition. So then we performed the anti-reflux mucosectomy in 100 cases. So we encounter another interesting patient. So this is a case, the open hiatus, NERD, no sliding hernia. Then we perform the arms procedure like this, like a butterfly shape, so in order to avoid the dysphagia. So, and then after that, so junction becomes a little bit tight, but not enough. So patient said, sorry, no effect. So we think that the junction is still open. So we need to do once again to this patient. But everybody knows. So second, mucosal resection with the tight scar is a very challenging, technically challenging. Then we thought that, so we can only do the ablation. So it's a simple method. So everybody knows using APC, we coagulate the gastric cardia mucosa. So after this, following days, the ablated area becomes the ulceration. And then, so 1 month after procedure, junction became tight. It works. And this is a symptom score. So dramatically improved. Patient satisfaction was very high. So, yes, PPI, stop. Then we report that this result. Oh, this is a beautiful lady doctor. So she reported this technique. Okay. So this is the sample of ablation. Yes, top line is the open hiatus as a place, the semi-circumferential mucosa ablation. This is very simple. So just the APC and the split. So everybody can do it. And the day 4, the ablated area becomes the ulceration, same to mucosectomy. And then, so 1 month after procedure, junction becomes very tight, like this. So the bottom line is also another case. So similar results. So well controlled. Yeah, this is another sample. Now, and then, so this is a design of ablation. So we place a horseshoe shape, semi-circumferential ablation. The point is a green line. We have to keep 1 centimeter from the junction. Then the patient has less risk of complaint dysphagia. This remaining mucosa works as a cushion of the scar and the junction. So very simple procedure. So this is, now we perform the 45 cases. So this is the data at the time of 36. Okay. So symptom score improved, not perfect, not like a toupee fundoplication. Of course, no, not like a toupee fundoplication, but acceptable, I think. So procedure is very simple. So this is the data of a pH study. So some of them don't want to receive the pH after procedure, so the reason why is a half dropout. So this is my conclusion slide. So first, endoscopically, we can evaluate the level of the sliding hernia. So if the sliding hernia component less than 3 centimeters, we can perform some endoscopic treatment. So we are doing several things, but now we are doing the ablation. It's a simple procedure and a cheap, less expensive. So I think unfortunately, I'm surgeon. So I do the laparoscopic surgery toupee fundoplication. Used to be a Nissen, but now we are switching to toupee fundoplication. And we have the treatment gap in between PPI and PCAV and the surgical treatment. So we want to fill this 25 or 30% gap by the endoscopic treatment. So at this moment, I think I recommend armor procedure. This is a very simple and so-so effective procedure. So this is an additional slide. Of course, Nissen fundoplication is full degree, so full circumference is the strongest. And the toupee is a little bit mild, and the armor procedure in between. Though is anterior partial fundification, a little bit weak, and like that. So, okay. So, again, this is the last slide, must be. So, we can just evaluate the flat pattern and up Q pattern, and, if we connect the line to the calculator, but just checking the patient's burping phenomenon, so we can say this is a slow belching and a rapid belching. So rapid belching patient, no need to perform this procedure, but we can do this. So I think we can call this procedure is a functional endoscopy, but I hope we open the door to the functional endoscopy. Thank you so much for your kind attention.